Bonjour. Today I would like to share with you about the real value of the DARE and what does the consensus 2018 says. My collaborators, Jay Parvizi and Torsten Gerke. So if you talk about the revision arthroplasty of PGI, it's a significant challenge for both the surgeons and the patients. For the surgeons, it's a challenge because it's quite difficult to remove a well-fixed prosthesis. It's difficult reconstructions, potentially compromise soft tissue envelope. So the ideal end result of the PGI is actually implant retention without infections. Why surgeons prefer DARE? Because a lower morbidity, bone-preserving procedures is reduced hospital lengths of stay, less technical demands than 1 or 2 states, and significant decrease in economic burdens. So it's not until the end of 2016, if you look nowadays in the PubMeds, a lot of publications on DARE. This paper from Jay Parvizi shows that DARE is still performed at a relatively high rate despite an inability to consistently control infections. It's still a source of controversy, has to be done in acute post-op and acute delay infections. So if you look at the success rate, it is lower than 1 or 2 states revisions, and the predictors of a lower DARE success rates are virulent organisms and symptom durations more than 5 days up to 4 weeks. There are some highly variables that is due to the lack of consistency for definitions of an acute infections, no consecutive series, and multiple surgeons in a single study. What does the consensus say? That if you look at the recommendations that exchange motor components, about 93.3% success, performing DARE within 7 days of onset, about 90.7% success rate, and also important to add rifampicin and combine with fluoroquinolone. If you look at the votes, about 92%. So is there an emergency procedure? No, but it needs to be performed on an urgent basis with the acute PGI patients are medically and surgically optimized. Again, agree 97%. So does identifications of the pathogen prior to the performing a DARE help to guide the surgeon's decision making? Of course, its identifications is desirable, but should not promote further biofilm formations before surgery. Again, it's a strong consensus. So in Holland, we have this leak study. Look at the nationwide randomized control trial to find the best way to treat the wound leakage. And we look at what is the optimal timing, whether it's 9 to 10 days, and this based on the most recent PGI meeting and the usual clinical practice in Holland. So I think the indication for DARE is if it is acute infections less than 3 weeks or acute hematogenous infections less than 2 weeks of onset in a well-fixed and well-positioned prosthesis and a good soft tissue envelope and patient with high risk of complications in more aggressive surgery. So the decision to retain depends on not immunocompromised patients, PGA caused by low virulent organisms, and biofilm containment. If you look at the X-ray, you have to be very careful because rarely show evidence of infections until you open it. So it's very recommended to have a revision set when you do the DARE. So again, the indications, as I told you before, within 3 weeks. And why don't we do it in chronic? Because major biofilm with persistent cell can be cured only by removing the implant. Agree about 80%. That's the CLIC score. It's a relatively good pre-op risk score for DARE failure in patients with early acute PGI. We wrote this paper published last month in Arthroplasty, and it's shown by Dr. Ferry about the most important thing, how to diagnose what is the criteria 2018 for PGI. So when you do DARE, 3 things that you have to consider: must decrease the burden of the biofilms, is crucial to identify culprit agents, Antibiotics withheld until the representative samples identified. The technique, it has to be, as been shown by Dr. Bauer, aggressive debridement of all the fossilized tissue and replace the exchange modular components. What does the consensus say about the modular exchange? That agree 94%. How about the change of the drips? Regional is unknown, but again, it's a 94% agree. And exchange of the instrument pre-implants is, of course, is yes, and agree 90%. So that's two controversy on there. Is failure in their effective subsequent revisions, and how long do you have to give an antibiotic? This paper from Christopher Sherrill, who wants the Tit Ranawat Award, he says that look at the two-stage reimplantations after failed irrigations and debridement, 34% failure rate. But another paper from Brum shows that failure rate of two-stage TKA not increased by prior fail of IND. What does the recommendation say? No conclusive evidence. Two previous studies shows that higher failure rate after two stage, while the other two more recent shows that does not increase the risk of failure subsequent to stage. Again, it's a strong consensus. How many times you can do there before two stages? The most important is resections arthroplasty should be performed, considered after initial their procedure. Again, agree 86%. So how long do you have to give antibiotics? Short, 8 weeks, or long, 3 to 6 months. There's no difference between the two groups except for a higher rate of polymicrobial infections in the long scheduled group. And this is from the consensus. 6 to 8 weeks of antibiotic therapy seems to be sufficient in most PGI cases to treat DARE. Vote again 91%. And also we look at the DARE and megaprosthesis. It's about 96% strong consensus. And DARE in UKA is also 96%. And we'll also look at the other, like intra-articular antibiotic and how many volume of irrigation you have to do, and how about there in fungal. Thank you very much.